Good evening, everyone, and welcome to our third episode of Pain Consultants USA's podcast. Today, Dr. Bonner and I are going to be talking not so much about a medical condition tonight, but more about kind of what's inspired us along our journey and what's kind of gotten both of us to this point. So, in addition to learn a little bit about ourselves, we want to educate you on what our background is, specifically that of physiatry, how that translates into managing patients with chronic pain, as well as how all of this relates to our company, Pain Consultants USA, which is a telemedicine based practice. So, good evening, Dr. Bonner. And if you could, can you start us off with sharing a little bit about your background?
Absolutely. Good to talk to you again, of course. So I'm originally from the Philadelphia area and grew up there my whole life. I then went to Georgetown University for my undergraduate education, and I studied physics. Actually, was my major there, and I had a mathematics minor. And then after that, went directly to Temple University in Philadelphia for medical school. Um, and then while there, took an interest to physical medicine and rehabilitation, which is, of course, our specialty. I have a unique history in that aspect, in that my father is a physical medicine and rehabilitation doctor, as well as I think five of my uncles and also my grandfather. So it's kind of the family business. And now, actually, my youngest brother will be going into it once he finishes his residency, which will be a few years from now. So quite a few people in the family doing the same type of specialty, and then after Temple Medical School, stayed at Temple for residency, which is of course where we met, and we were at Temple University Hospital and Moss Rehab Hospital, which is in kind of northeast Philadelphia. Um, and then after residency, I did a fellowship at the University of Pennsylvania, uh, doing what was termed a spine, sports, and musculoskeletal medicine fellowship. And so in that fellowship, we were seeing all kinds of patients with back pain, neck pain, any kind of joint pain, any kind of musculoskeletal issue, and then trying to determine treatment programs. And a lot of times these patients had seen many different physicians at that point. So we were kind of doing specific targeted treatments, which I think you would, or procedures, which you probably did as well in your fellowship. And then after fellowship, moved down to the Miami area, where I've been for the last almost 3 years, and have been practicing mostly in a Medicare Advantage population. And for those who might be listening don't know, Medicare Advantage is a type of Medicare where it's based on value-based care. So instead of fee-for-service care, which is kind of the most common and classical thing we see, where you go to the doctor, your insurance pays a certain amount of money for the visit, and the doctor receives that money. Value-based care is more you're paid a certain amount of money to take care of the patients, and then with that amount of money, you're expected to take great care of them, but save enough of the money that the businesses can make a profit in the value-based world. So that's where I've been for the last 3 years, trying to help the company that I work for kind of keep control of musculoskeletal, orthopedic, pain management costs, which, as we've talked about, can get pretty high when patients are getting lots of procedures that may be unnecessary, or lots of surgeries that may be unnecessary. So my role there has been to kind of keep help keep control of all of that situation, do procedures when they're necessary, and help the patients understand when the procedures aren't necessary and what the other treatments might be available to them. So that's where I've been, and that's where I am now. And now we're kind of getting this going. So we'll talk more about that, but maybe you can talk about your background a little bit too.
Yeah, no, that's great. Um, I think the first time we met was we were interviewing out at
Yeah,
Northwestern.
I
We
think
ran
you're
into
right.
each
Yep,
other.
absolutely.
Yeah,
Yeah,
so
we were
a
both
long time
interviewing there,
ago.
and you were like, "You're gonna go to Temple, right?" And I was like, "Oh yeah, I'm probably just gonna go to Temple." And you were like, "Yeah, me too." Yeah.
The good old days. Um, but yeah, a little bit about myself. So I originally grew up in the northeast part of Pennsylvania. I did my undergrad at the Pennsylvania State University, where after that I went on to medical school in Philadelphia at Philadelphia College of Osteopathic Medicine. Then along the way, kind of figured out or was introduced to physical medicine rehabilitation. Unlike you, I don't have any, my entire family was not in physiatry. But once I was introduced to it and learned a little bit about it, I knew that was kind of the avenue for me. So went on and did residency at Temple, like you mentioned, and Moss Rehab. And then for fellowship, I did a pain medicine accredited fellowship through Dartmouth in New Hampshire. It was actually through the anesthesia department, where we took care of patients medically, both on the inpatient and outpatient side, as well as then interventional procedures throughout the spine when appropriate. After the year in New Hampshire, moved back to Pennsylvania and currently practicing in a private practice group in the northeastern part of the state. Practice is primarily spine and chronic pain related. I still get to see some musculoskeletal, peripheral joint thing, pathology, which I enjoy. We are in the fee for service model, so unlike you, so we have both perspectives on that. Um, yeah, and we're I think this has been a 2-year process in the making. When we probably even more than that when we first started talking about this idea of bringing spine and musculoskeletal medicine uh, to telemedicine or utilization of telemedicine.
Yeah, I
So,
think we had a handful of conversations definitely before we put anything formal together, but I think we both express frustration about why our patients, not getting enough education and us not getting enough time with patients and things that every doctor kind of complains about that make their jobs difficult. And we thought this would be a great way to kind of be able to get set allotted amounts of time with patients without lots of distractions going on in the physician's office and other things like that. And a lot of people go to a pain doctor or a musculoskeletal medicine doctor looking for some kind of procedure, but a lot of times a procedure isn't the solution, and the solution is really education and a specific exercise program, which is something that we can probably, we hope deliver very well through a platform like this. And so I think that's how, I feel like that's how we kind of came together with this. Or like, I don't, people think I do procedures on every patient I see, and in reality, it's probably less than 5% for me. It's probably a little more for you, but it's still, there's still so many patients who can benefit from appropriate education. And, I had just a friend the other night who I was eating dinner with and was telling me that his back had been hurting a little bit and he had an MRI, and, he was told by a neurosurgeon to strengthen his core, and that was really it. And they said that, there's nothing surgical there. And, I went in with him based on what he told me and, started describing all kinds of things that he could do because, it's something that in our specialty, we're definitely better educated on kind of the exercise-based treatment and the lifestyle modification-based treatment. For this guy, it was mostly just picking up his kids off the ground that was really bothering him. And, it was a 40-year-old guy. It's pretty clear that's a lumbar disc problem. Like, until proven otherwise. And that's what the MRI probably said. And so, I just talked to him for 15 minutes about some lifestyle modifications. And, I think his wife texted my wife later saying that, like, oh my God, like, couldn't believe that, like, someone had information like that to, like, help him through this. And he's a doctor himself. So, but he doesn't do this kind of work. So, hopefully we can provide that kind of education to lots and lots of patients through this. So.
Yeah, no, that's a great example, and I think kind of I echo your frustration with the way musculoskeletal and pain medicine is currently delivered. I mean, there are a lot of barriers to being able to take the time to educate our patients the way we'd want, and to really review previous care rendered. I know personally when nothing seemed to frustrate me more than when I would get a patient in for a second opinion, or they might have been through 3 or 4 different pain docs. And the primary objective with those docs, as you could tell based on their records, was, this is what procedure can we do? And procedure has to help. And they really kind of ignore the other, the whole physical medicine approach, as well as the education that's required for a lot of patients. We take for granted you might know what to do with a disc issue, but like you highlighted, other physicians don't even know kind of what they can or should do, especially if they're not in this area or don't practice this type of medicine. So,
So you brought up
I
there.
think our background.
I was say you brought up there,
Good.
the physical medicine background. So, and you did a fellowship that was based in anesthesia. So I don't know if you could maybe, mention some of what might be the differences patients may not know. You may be seeing a pain doctor. If you see someone for back pain, you could see any range of physician, right? You could see probably first your family doctor. You could see a sports medicine trained doctor who could be a family doctor, a physical medicine and rehab doctor, or separately a more surgical type sports medicine doctor, an orthopedic surgeon. You could also see a neurosurgeon, and I even see a lot of patients who see a neurologist. And then you could also see a pain boarded specialist who could be someone in physical medicine and rehabilitation, someone in neurology, or someone in anesthesiology. So I think I just named like 10 different types of physicians that you could end up at for a problem like low back pain. And that can be probably pretty confusing to patients sometimes. And, I think probably even a lot of physicians don't even know the differences between the trainings and who may be better for different problems and things. But I know you worked with a lot of anesthesiologists, so maybe was there differences that you perceived there from your training there versus the physical medicine and rehab training before that?
Yeah, great question. Just to back up and add to what you mentioned, when you see a pain specialist or someone boarded in pain medicine, there's even additional avenues now, albeit rare, psychiatry,
Yeah.
and I believe even emergency medicine now. And there's been some avenues where some family physicians can go the
So
pain medicine route.
why do you think
So,
this is the case? Why is everyone doing pain?
I think there's a lot of different reasons. I mean, one is there's definitely a need for it, um, but it's hard to understand a lot of motives of different colleges. And when I say colleges, I mean specialties.
Sure.
So within medicine, so
Sure.
whether family physicians or emergency medicine physicians, anesthesiologists, or physical medicine rehabilitation specialists. But the two most common types of physicians who go into pain medicine are anesthesiologists and physiatrists or physical medicine rehabilitation specialists, which we are. Traditionally, I think when you think of pain medicine from years prior, you probably think of the anesthesia doctor who did epidurals in the basement of the hospital just by feeling the back, and then they kind of transitioned up to doing guided epidurals and things like that. As medicine has changed with regards to um, what family doctors treat nowadays. So think about it years ago when it was solely anesthesia, and anesthesia, they're trained kind of from say the top down. So it's a pyramid. The top is the intervention or the procedure or the surgery. And at the bottom is kind of the physical exam and the foundation for building, or diagnosing what the actual cause of the pain is. So years ago, when everybody saw their family physician and the family physician took care of everything, and then would just refer for a specific issue, right? It made sense. Family physician would do an exam, diagnose you with the condition, send you to the pain doctor, possibly for an epidural, right? So that top-down approach would make sense back then. Nowadays, medicine has become so subspecialized that oftentimes a family physician, knowing their limits, will say, "Oh, you have back pain or neck pain or arm pain that seems to be traveling from your neck. You have to go see a pain doctor." But really, none of the workup, none of the education or the diagnostic part of it has been completed, unlike years ago. So now, when you see a pain doctor, you really need to start from a bottom-up approach, meaning, get the accurate diagnosis, appropriate conservative care, and work your way up to possibly an intervention if appropriate. So that's the big difference with our training. Again, physical medicine rehabilitation. Half of our medical training consists of the base of the pyramid, right? Working with patients with various neuromuscular and orthopedic conditions. So we're seeing 20 to 30 patients a day in our clinics, in the EMG lab, and really working these patients up from the beginning. And then as we go on to fellowship, we obviously learn the more detailed procedures and the procedural aspect itself. So that's the biggest difference. So, all right. So when we come in, or patients with, or physicians with our background, we have the base of the pyramid already established and our foundation is strong. And then we work our way up, where anesthesia, with no fault of their own, they start from the top down, right? So during their training, they're caring for patients in the operating room, right? They're giving sedation, they're doing some epidurals and whether blind or under image guidance for certain surgical procedures. But they really don't get the exposure to the musculoskeletal aspect. So, the colleagues I worked with were great. I mean, we learned from each other. But I think it's really important for patients to understand, like you said, who they're going to see. Because if you're going to see somebody who's really good at doing a procedure, whether it's a radio frequency or an epidural, but they can't examine you, they can't educate you on a condition, and they can't really give you a true diagnosis, well, the injection or procedure may or may not work, but that's the only tool in their toolbox, right? If that doesn't work, well, then they're going to ship you back to your family doc, who's going to send you to another doctor. So I might be a little biased, but I think with our background, really learning the neuromuscular system, I think we're in an ideal situation to, first of all, diagnose patients, work them up, educate, and then, as long as we have the training, which both of us do, to treat with appropriate interventional therapies.
Yeah, so I think that we should just highlight for people that when we do our residency training, we spend, like you said, we spend really half of the residency training in inpatient rehabilitation facilities. And in those facilities, we're helping to rehabilitate people who have most commonly strokes, spinal cord injuries, traumatic brain injuries, and then a lot of people who have multiple joint replacements and then major traumas and things. And so these people are staying in the hospital for months with severe, like you said, neurologic musculoskeletal deficits, and we're helping to rehabilitate them back as close to as possible as close to their old selves as possible. And so that's one half of our residency training. So that's just, seeing patients who have already had a severe deficit and then helping them gain that deficit back. And then the other half we spend in all kinds of different clinics, like you said. So, we spend multiple months with orthopedic surgeons, watching them and working with them, and some of us even going to surgeries with them. Um, we spend time with the neurology team. I spent multiple months with neurology throughout my residency training. Um, we spend months doing the electromyography and nerve conduction tests, as you said. Uh, we also spend months with some family medicine trained sports medicine doctors, some physical medicine rehab trained non-fellowship doctors, sometimes pain boarded trained like you are, or other fellowship training like mine that is not accredited, but has a slightly different tone than maybe the anesthesia-based pain fellowship. So we spend time with, you know, a lot of these different groups of people to see what are the different approaches and what are the different things that work in different settings. And so I think that we get probably the most comprehensive uh, perspective about how to take care of a lot of these patients. If you're doing an orthopedic surgery residency, I don't think that you're spending, maybe we had them come spend a month with us, but I don't remember too much. I don't even think so. Neurology residents don't really come train with us, so I think that we did a great job of spreading out and seeing what everyone else is doing, and then using that to our advantage. And we may do that better than other specialties do. And of course, we are biased, so we are not going to hide that. we,
Well, I mean, we're obviously biased, but I mean, I think we can make the argument that, like you just said, for the reasons you just stated, there is no other specialty like ours, right? It's a small specialty. Most people, when you say physiatry, never don't even know what you're talking about. But with the unique training, we really are groomed or set up for taking care of patients with various musculoskeletal issues, right? A majority of conditions aren't surgical in nature. Not all conditions require a procedure, but every condition requires an accurate diagnosis and education. And nearly every condition, whether it does end up going on to surgery or intervention, requires the appropriate conservative care first. There's no other specialty that is set up to take care of patients from start to finish like we are. I tell a lot of my patients that think of us as, or think of me as your primary care physician for all of your neuromuscular or musculoskeletal issues. So you have an ache or a pain, you come to me,
yeah,
right? And I think you would probably agree with
I
that.
mean, that's basically what my current job is. I work in primary care offices and I provide care for patients with musculoskeletal complaints in those offices. I go to the offices and I care for the patients in their home primary care office, so that they could see the primary care doctor and me, the primary musculoskeletal care doctor, in the same day. And um, and so, that's exactly the model of my practice, and I think it works out great because so many patients realize that we're able to help with so many different types of issues. Sometimes I get a lot of patients who are like, I'm treating them for one problem, say like their low back, and then they're like, oh, well, I'm going to this other doctor because my knee started hurting. I'm like, well, you don't need to do that. I can do the knee, and then it's like, oh, well, I have carpal tunnel syndrome. It's like, I can take care of that too, so there's such a wide array of diagnoses that we can help manage conservatively, as long as it's not a surgical issue. And even if it is a surgical issue, we're certainly trained to help identify when that's the case. And that's the most important thing, is to really be able to identify the diagnosis, like you said. And then, is this an emergent issue, or is this an urgent surgical issue? And if not, then how do we go about treating it? That's kind of how I like to think about things. Do I need to do something about this right now, or in the next few days? And if not, then we slow down and go from there.
Yeah, and I think with that being said, and almost similar to the model that you're currently practicing in, our overall goal with this new endeavor, uh, seeing patients and treating patients through telemedicine, really is to bring our services to the forefront and improve access to what we deem and what we're biased as calling appropriate care for a lot of these conditions. It's almost the modern day house call for patients, and that's where telemedicine, which is growing, is going to continue to expand, is really can serve a purpose for a lot of patients who first need an accurate diagnosis, which again, that's what our foundation and our background in medical training has been built on. And then to establish a treatment program for patients, and I hate to say it, but when we see patients for second opinions, I mean, we know whether or not they received appropriate care, whether it's from another non-operative specialist or a pain specialist or even a surgeon, right? I mean, we know when appropriate care was rendered or not. And, first and foremost, our mission is, to treat our patients. So we're going to be honest, and we're going to make sure they get the appropriate care
Yeah, and I
they
think just
deserve.
on top of that, I think everyone who listens to this should know that the main goal is really to provide appropriate education, because, you know, there's nothing better for us than if you can come to our website or our podcast and listen to one of our podcasts or read a post and figure out how to make yourself get better, and not have to go through, you know, tons of hoops and different procedures and different tests. If you can listen to one of our podcasts and say, that sounds like my problem, and then listen to what we say and then get better because of it, that's the ultimate goal here. We want people to be able to take control of their care. And we're hoping to provide material for people so that they can do that. And if you're ever looking for specific material, or you have a problem that you don't see that we have material that's based on it, please reach out to us. We can always kind of lend a helping hand. But, the goal here is to provide lots and lots of material so that patients can educate themselves on their conditions and on how to appropriately treat them, because a lot of them can be treated with just some good education about it. So that's really what we're here to do.
Yeah, exactly. So, I hope this little talk will be helpful for patients. And again, when you're seeing a physician or you're being referred to a specialist and it's a pain specialist, do a little research on them. Are they an anesthesiologist? Are they a physiatrist? Or are they another specialty? Same goes for sports medicine or other operative specialists. Do a little research on your provider. It's always good kind of to know what you're getting into ahead of time. And, just to kind of echo what you said, one of the biggest things for patients too, don't be afraid to ask questions. right? Physicians are there to educate. So if you're leaving the office and there's questions that you don't have answered or you don't understand something about your condition, stop whoever you saw and ask them questions. But we also hope to be that resource that you can go to for trusted information. So that being said, I think that was the primary goal of tonight, just to kind of give you guys a little better understanding of who we are and why we're doing this. So we'd love to hear any feedback, which you could post on our YouTube page or on our Facebook page, or feel free to reach out to us via our website. We're here to help. So,
Yeah, we'll
Dr.
talk to you
Bonner,
soon.
good talking to you as always.